Hello, everyone, and welcome to RMD, All Things Aesthetics and Wellness podcast with me, your host, Dr. Deborah Durst, and my co-host, Farideh Golem-Bieski.
Yep. Hey, guys. You're so good at it. You've got it down.
I got it down. It took me a year. She's correct.
That's okay. We got it down.
Farideh is my co-host here every time.
Every time. So I'm a family nurse practitioner here at Revitalize, and today we're going to talk all about hysterectomies, the types, why we have them, what they're for, why you should, why you shouldn't.
And, changes your body might go through after, and, how is sex after. So again, some facts, 500,000 hysterectomies yearly. And it doesn't seem like a large number, but, and I'm actually not quite sure if that is going down or up. It seems like it should be going down.
Should be, but I feel like almost the majority of the women we see in office have had one of the types of hysterectomies, have had something going on. So I was actually kind of surprised. I thought it would be higher, but that is a big number.
And, basically, so there's different types. And so a lot of people don't understand that difference. And so if we were to break it down in simple terms, a full hysterectomy is they're taking everything, the uterus and the ovaries. And a partial, grossly, between the two is that they're just taking the uterus and they leave the ovaries intact so that you can still produce hormones because you're pre-menopausal.
Yep. Or so maybe even just a portion of the uterus for very, very minimal, which is just a portion of where they leave some of it behind. And that could be just because of sexual dysfunction. That is not going to treat a prolapsed uterus. It's not going to treat fibroids. It's not going to treat endometriosis. It's a very minimal invasive surgery, which I don't really know how many of those
it's actually do. It's relatively new because, again, I did not hear a lot about them, but I'm assuming that that's something that's coming. They're just getting more advanced in their surgical techniques. And so they used to just remove the whole uterus, including the cervix. And so now just removing the upper part maintains the cervix, which might help with sexual function. But also, just to make it simple, it's not going to help with complex diseases. So if you have, fibroids, anything in the uterus, endometriosis, those kind of things, then you don't want to get, or you don't want to have a hysterectomy that leaves part of your uterus still intact.
Exactly. You'd want the whole uterus removed.
Yes, correct.
And then there's radical hysterectomies, which is everything. So that's typically if there's some type of cancer where they're removing the uterus, the cervix, surrounding tissues.
And even some of the vagina.
Absolutely. So that's going to be your most invasive, not as common, but again, that's more treating cancers.
Definitely the one that you don't want unless, again, it's needed for cancer reasons. And otherwise, you're going to hear partial and full for the most part. Yeah. Partial means, again, you have the uterus and the ovaries. They maintain the ovaries for hormone production in a partial hysterectomy. And
the cervix is usually left in a partial.
Yes. Yeah. So, and that's what we were kind of talking about with it depends, I think. Sometimes they used to take the full uterus and now they're taking, or they leave the cervix and sometimes even more of the uterus. So, but grossly, your ovaries are definitely still intact with a partial because you might have had your partial hysterectomy 20 years ago. So you still maintain ovaries with partial and your uterus and ovaries are gone with a full. And the interesting part is they don't take your ovaries hoping that if you're premenopausal that you can still produce hormones. And the question is, do you? Because a lot of people have problems right after a hysterectomy, changes in sleep and the way they feel. And it's a big deal for women. And
mood, sometimes even depression.
Yeah. It's been a big deal. And so again, even with tubal ligations, that can be the case when they're tying the tubes, which they're doing more advanced techniques with as well. But because the blood supply to the ovaries and the uterus is somewhat connected, when you take out the uterus, you may have a decreased blood flow to the ovaries and therefore a decrease or a stop of your hormone production.
Absolutely.
With your partial hysterectomy. So even though they leave the ovaries there's a potential that the blood supply might be affected and you might not produce hormones.
We get asked that question a lot. I feel like in clinic, we'll have women say, well, they left my ovaries, so I'm sure that I'm fine estrogen-wise. Or I had a total hysterectomy, but nobody put me on anything and I'm having hot flashes. and then I'll say, well, they probably took the ovaries. Well, no, I don't think they did. Well, if we had a total, they probably did. So it's also kind of clarifying the terminology around patients as well. Yes. So when you're going to see somebody for hormone replacement, or if you've had a partial or a total, either way, it's really important to kind of get that history to know when was your last period? Why did you have the hysterectomy? Obviously after the uterus is going to be removed, we're not going to have a period anymore. So we don't have that indicator for menopause.
So you cannot use that for a determination of how long ago you had your last period.
Exactly. And then also looking at, when you have your labs drawn, looking at your luteinizing hormone and follicle stimulating hormone, which will give us a better understanding of where we are in menopause and if we are making estrogen or not. And then along with what symptoms we're having. So definitely important to have everything looked at very comprehensively when you're seeking somebody out post-hysterectomy for treatment. I think it's something that I read, like up to 12 weeks post-hysterectomy, that you can still be cycling estrogen in the body and still have spikes in the body.
Yeah, usually it's at least 12 weeks before you want to start looking at hormones and hormone replacement. But we've had women in right after that want it yesterday because they feel that bad, because it is a rapid, you're just not making hormones anymore if you've had a total hysterectomy. And some women feel that, immediately. So what are some reasons why you might have a hysterectomy? So again, you can have bleeding. So basically, if you're looking at estrogen and progesterone, and those are the two main hormones that are affecting your uterus, progesterone has receptors throughout the body. So even if you've had a hysterectomy, you still need progesterone. That's a myth that is frequently repeated from the gynecologist. You've had a hysterectomy, you don't need progesterone. Well, there's progesterone receptors elsewhere. And as women know that are hormonally optimized and now sleeping well again and not as anxious, their mood is so much better. They're not responding. They don't, just get mad like that. It's because they have progesterone now.
Absolutely.
You have to optimize progesterone. And so honestly, reasons why we have a hysterectomy, endometriosis, bleeding, fibroids, all of those.
Prolapse.
Yeah, prolapse. But all of those bleeding conditions, it's estrogen and progesterone balancing each other. Estrogen does what we call proliferate or divide tissue, and progesterone works against that. So if the uterus is being, like, you have division of cells from an excess of estrogen and a perimenopause, which is what you do, because your progesterone will drop, your testosterone will drop, but your estrogen doesn't. So you become a little estrogen dominant, and you get division of the uterus and bleeding and fibroids and endometriosis and breast tenderness and fibrocystic breast disease, where in fact, progesterone may help balance the estrogen and help with those conditions.
Absolutely.
But if they're not on progesterone, then, and if they had, this issue of massive bleeding and the perimenopause and they're having a hysterectomy, again, there's probably a good chance that they're not going to be hormonally optimized by the doctors that are necessarily performing the surgery. So again, like Farideh said, it's very important to ask questions, see what they're going to do after. Do they check hormones? Do they optimize and find somebody that you can go to if they do not?
Exactly. And then we can also have some chronic pelvic pain and stuff like that that can lead to a hysterectomy.
Yeah.
But again,
and the prolapse is another important thing that you were talking about. Those are just not direct estrogen effects.
No.
But but can cause issues for sure.
The other thing we see a lot is that we'll have women that will come to us that are on estrogen pills. Pill form estrogen. So that is something that I think that we talk a lot about in the practice here. Most of those women we take off of a pill form and put them on a cream, and then eventually a pellet form with time. With the pill form of estrogen, we have higher risks with clotting and more clotting factors, and we can see that high risk for deep vein thrombosis and blood clots. So we like to take them off of that and switch them over to a cream. Some women will go to a patch, but usually it's a cream until we get them hormonally optimized. Then we swap them over to a pellet.
Yeah, because if your body hasn't seen estrogen in a while, then there's a potential that you might get some side effects such as bloating or breast tenderness. And again, we're talking about hysterectomy, so you're not going to have vaginal bleeding. Exactly. But if you still have a uterus, you could potentially get vaginal bleeding. So that's when we want to do cream first, get your body used to it again, and then we can switch over to pellets, because ultimately that is the low the low work kind of like, you don't have to think about it. It's a no-brainer. You just put the pellets in and then you're going to optimize your levels and not have to worry about taking anything. So, and definitely, you're right. The pill form can potentially increase your clotting factors and some clotting. So that's not the route that we use here.
There are, there's multiple different ways to treat. It's just a little bit different. We talk a lot about traditional versus functional, and it is just a different way of doing it. It doesn't mean that being on pill estrogen is necessarily wrong. It's just not the way that we treat.
Yeah, there's lots of different ways to do it. And so we just prefer a different way. There are FDA approved pills for it.
Absolutely.
So it is definitely a common way to use things. And again, we like to compound things because then we can also customize it for the patient and we can adjust things. It's not just one pill and one dose for everyone, because if we did creams, we can adjust back. We can do 1 click or 4 clicks and we can adjust the concentration so it'd be specific for you and your symptoms of the patient. So,
and then we can also do bioidentical that way.
Yes, exactly.
So non-synthetic form. So a bioidentical estrogen option. So something that is derived from a plant source or animal source.
Yeah. Well, and actually, so some of the pills, there's some pills that still are bioidentical and use the estradiol. And then the patch too is another thing that you can use, which is bioidentical. But again, those are still just one concentration, one dose. You're either taking it or you're putting it on, where we can adjust with the compounding, and it's still bioidentical and just works very well for symptom control for women. But, the question is, again, with sex and, how does this affect? So I'm having hysterectomy, I'm having my uterus, potentially my ovaries removed, what's going to happen after? So again, we've already talked about the hormonal changes that can go on. And again, if you're having a total hysterectomy and you're having your ovaries removed, then you're definitely going to have a decline. And, 12 weeks is about the time we'd start to look and optimize. But even if you've had a partial, there's a good chance, or at least I should say a small chance, and there's some studies, it's mixed for sure.
Exactly.
Some of them showed no change in hormones, and then others showed changes in hormones. So, and I just know from experience that a lot of patients come in and their symptoms happened shortly thereafter.
And they're pretty quick.
Yeah. Mm-hmm.
Yeah. So, and we know going into that for those patients that we may have a spike or we may see a spike in estrogen. So again, by going with the cream that we can compound for that patient and then drop back clicks, increase clicks, kind of really work with what's going on with them is really important. But so you have a hysterectomy, depending on the form of hysterectomy and what all they're taking out and kind of how that afterwards, how that trends. Not everyone goes right into menopause. I think that's kind of where we were going is, okay, I'm having this hysterectomy. Am I now going to be in menopause? Maybe is kind of the answer, depending on what happens. But tracking that blood work afterwards is really important. And then again, what does that mean for sex? So if we're not making estrogen, typically what we hear from women is vaginal dryness, painful intercourse.
And potentially estrogen could have, a small effect on libido and even orgasmic strength. But then again, how do your orgasms change with a hysterectomy? You're removing some female organs. And so how does that change things? And I think it really just depends, again, on the person. If there's any cervical component, like primarily we're talking about clitoris and G-spot for orgasms for women. And, we have conversations. Do you have just clitoral? Do you have internal? But some women have a cervical component, or as part of their orgasm, they have that spasm and contraction, and the uterus and cervix is part of that. Yeah. So they may experience some changes as they transition out of that hormonal, phase, and they also have missing organs now. So it depends on the person.
Yeah. I had a patient that had said that after her hysterectomy, that was one of the biggest things, is because that pressure applied to the cervix during intercourse helped her get there orgasmically. And she's like, it's just gone. So, it's interesting, even when we're doing our research for these podcasts and kind of looking at the articles, that was brought up a few times. And it talks about, okay, well, learn about other erogenous zones. You got to figure out what else turns you on, what else is going to bring you that pleasure. Because if it was that pressure against the cervix or those uterine contractions, and it wasn't so much about the G-spot or the clitoris or that, what other ways are we going to get there? What else brings you pleasure? And kind of finding that and starting to kind of fret out that your own sexuality there of what you like and what you don't.
You got to
change it up a little bit.
Yeah, you got to change it up. Got to adjust things and see what works now.
Exactly.
Because if something's gone and that was part of it, then now you have to find different ways and explore that with your partner or yourself, and find what other things work. But then it also brings to the point, like, again, if you weren't on any hormonal replacement. So I would say leading up to a hysterectomy, because there's a lot of times that it's being done for bleeding of some sort, fibroids, endometriosis, vaginal bleeding that's excessive. And so they haven't been on progesterone. So most of those patients have not been on testosterone either. So as you're exploring different options for how to have better orgasms after a hysterectomy, testosterone is very helpful for a drive and orgasmic strength as well. So if we're seeing somebody post-hysterectomy, we're going to be addressing that anyhow, which can be life-changing for women.
And we're always looking at those progesterone levels too, as Dr. Durst had said, even if they don't have a uterus.
Yeah.
We are always looking at those progesterone levels with the testosterone and estrogen as well.
Yeah. And think about it, like when we approach our perimenopause, like 40 to 55, that perimenopause, menopause, but the first thing that drops, progesterone and testosterone. And so what do we have trouble? Sleeping. This isn't related to the hysterectomy, but we have trouble sleeping. We're anxious. Our mood is not as good. Irritability. And the first thing they put us on is, again, sleeping pills, antidepressants, anti-anxiety. And what we're deficient in is progesterone. So, just if you're not on progesterone, you need it after hysterectomy, but you also need testosterone.
Absolutely.
And as you're exploring all those other different ways to have orgasmic strength, testosterone would be very helpful for that. So
if you guys have any questions about hysterectomies, about what that process looks like, how we would go about treating, you've experienced it yourself, if you were on hormone replacement after hysterectomies and how it changed your life, definitely leave comments below. We'd love to hear your all stories.
Yeah.
And then,
well, especially so since we're talking about mixed studies and mixed reviews on whether your hormones decline after a hysterectomy, a partial, then it'd be interesting if you've had an experience with that and you've had a hysterectomy and you've noticed a change right after, then it'd be interesting. It'd be very helpful for you to share that with not only us, but with our viewers. And, could even start a conversation throughout the comments. So that would be helpful. And again, we want to hear more about your experiences, what you want to hear more about. Like, subscribe, hit the bell, share with friends, and let us know anything else you might want us to talk about. Because again, we're here to revitalize your look, your health, and your sex life. Thank you.